All right, welcome everybody. I am going to just go ahead and share my slides here. So we have, this is our bariatric happy hour. Thanks everybody for joining. My name's Laura Fisher, and Julie and I are the co-hosts of running these sessions. And we are, before I started, I just want to make sure that I let everybody know about the fellow project. Did I get lost? Sorry, guys. Let me reshare.
I think we lost you for 1 second, Laura, but you're back.
Okay, good. All right. Can you hear me?
We hear you now. Yes.
Perfect. Apologies. I've been having IT issues tonight. But yeah, so just wanted to make sure everybody knows about the Fellow Project. It's the first Friday of each month at 7 a.m. Eastern and noon Pacific time. And it will fulfill all of your didactic requirements during fellowship to get your ASMBS bariatric certificate. And they are free and anybody can sign up, and they're really fun. So tonight we are doing a journal club, and we are going to be talking about how bariatric surgery can affect risk and mortality from cancer, which is a really hot topic right now and was the topic of our keynote address at the national meeting this year. The article we're going to be talking about is entitled Association of Bariatric Surgery with Cancer Risk and Mortality in Adults with Obesity. And our two discussants tonight are Dr. Youngmi Choi. And Dr. Choi is the MIS and Bariatric Fellow at Duke University. She's originally from South Korea and then moved to England at the age of 12. She went to an international school before attending King's College London School of Medicine to earn her medical degree, while also obtaining a Bachelor of Science in Clinical and Molecular Endocrinology. She then moved to the United States to pursue surgical training and completed her residency at Rutgers in New Jersey, and also obtained an MPH at Johns Hopkins. She is board certified in general surgery and surgical critical care and is the current MIS fellow and bariatric fellow at Duke. Her clinical interests include gastrointestinal surgery, advanced laparoscopic and robotic surgery, and surgical critical care. And then the lead author on our paper is Dr. Ali Aminian, and he is the director of the Bariatric and Metabolic Institute at the Cleveland Clinic. He's also a professor of surgery at the Cleveland Clinic Lerner College of Medicine. He has performed extensive research in the role of minimally invasive gastrointestinal procedures for the management of obesity, diabetes, metabolic disease, and fatty liver disease. He has an outstanding record of peer-reviewed publications in high-impact journals, including the New England Journal of Medicine, JAMA, Diabetes Care, and Annals of Surgery. And his studies have been widely covered in the media, including the New York Times, Wall Street Journal, Washington Post, Times, CNN, Reuters, Newsweek, and Forbes, indicating their high importance from a public health perspective, which we all agree with. So I am very excited to have both of these discussants here tonight, and we're going to have a great session. So I'm going to hand it over to Dr. Choi to present the paper, and then we will spend the rest of our time having an awesome discussion.
Awesome, thank you. I'm going to start sharing my screen here. Where did it go? Yeah. Everyone see this okay?
Yes.
Okay,
It looks great.
All right. Thank you for the wonderful introduction. Thank you for giving me this opportunity to present today this really important paper. So this article I'm going to be talking about was published in JAMA, and it's called the Association of Bariatric Surgery with Cancer Risk and Mortality in Adults with Obesity, written by Dr. Aminian, who is here with us today. So the background to the study is done from the fact that there have been studies that shown that obesity increases the incidence and mortality from certain types of cancers in the past, and due to the growing prevalence of obesity, the burden of obesity-associated cancers are really becoming more widespread and significant. So currently, bariatric surgery is really the most effective treatment for obesity, as I think most of us know in this group. And patients can achieve, 20 to 35% of their body weight loss, but it still remains unclear whether weight loss can mitigate or even decrease some of the cancer risk associated with obesity. There have been some observational studies that suggest that there may be an association between bariatric surgery and reduced cancer risk, but there's really no reliable data on cancer-related mortality and risk after different types of bariatric, sort of modern bariatric surgical procedures currently. So the study called SPLENDID, short for surgical procedures and long-term effectiveness in neoplastic disease incidence and death. The main question of this study was, is there an association between bariatric surgery and the incidence of obesity-associated cancer and cancer-related mortality in patients with obesity? So it was a retrospective observational study. It was a matched cohort study in adult patients with obesity who underwent bariatric surgery, and essentially compare them to those who did not undergo bariatric surgery. The study enrolled, essentially retrospectively studied patients who were seen in Cleveland Clinic in Ohio and Florida. All patients had BMI between 35 and 80 between 2004 and 2017. They collected data from electronic health records, and they included patients aged 18 to 80 years. For the surgical group, they included those who underwent Roux-en-Y gastric bypass or sleeve gastrectomy. They exclusion criteria to exclude those presumably at higher risk of cancer, well, those with active cancer as well as those who are at high risk of cancer. So HIV, transplant, alcohol abuse, peptic ulcer disease, as well as those with very low EF, lower than 20%, who presumably have higher risk of mortality. Diagnosis of cancer was made based on reviewing notes and reports in the electronic health records. Then the matching occurred in a way that it was done in a 1:5 ratio matching using propensity score based on BMI, sex, race, and age. And they were also given these, what they call the index date. So the surgical patient had this called index date, which was which was the date of their surgery, and the neurosurgical control groups were also given sort of random mix of this index date that were picked out from the group of surgical patients. They had some statistical methods that, really, truthfully speaking, it was quite in depth. But essentially, they looked at the cause-specific events, specifically speaking, the event of cancer, as well as cancer-related mortality. They looked at both obesity-associated as well as all types of cancer, even if it wasn't associated with obesity. And in the end, they also talk about sensitivity analysis, which I'll explain more about during results section. So primary endpoint was the first occurrence of one of the 13 types of obesity-associated malignant cancers, and it's all listed here. And this included esophageal adenocarcinoma, renal cell carcinoma, postmenopausal breast cancer, cancers of the stomach, colon, rectum, liver, gallbladder, pancreas, ovaries, uterus, thyroid, and multiple myeloma. And secondary endpoints included incidence of all types of malignant cancer, not just the obesity-associated ones, and incidence of all cancer related to mortality. So they altogether had 30,318 patients, 5,053 of them underwent bariatric surgery, 66% of them had Roux-en-Y gastric bypass and 34% had gastric sleeve. And they were matched to the control group who did not have any bariatric surgery done in a 1:5 ratio. And that added up to about 2,500,000 people. Overall, the median age was on 46 years, 77% female, and median BMI of 45. So this is the first primary outcome, which is showing the Kaplan-Meier curve to show the cumulative incidence of the obesity-associated cancers. So the x-axis shows the number of years since the index date, and the cumulative incidence in the bariatric group was 2.9% versus 4.9% in the non-surgical control group with absolute risk difference of 2%. And through Cox proportional hazard regression model, they calculated the adjusted hazard ratio to be 0.68, which was statistically significant. And, you know, as you can see over the years, the difference sort of becomes wider. When they analyzed the primary endpoint by the surgery type, so dividing the surgical group into the Roux-en-Y versus the sleeve gastrectomy group, the cumulative incidence was still 2.9% for both surgical groups. And compared to the non-surgical group, the difference remained pretty similar. So over the pattern and trend sort of looks similar to the previous curve. And the adjusted hazard ratio was 0.7 and 0.66 for both groups, so quite similar. In terms of total cancers, including the non-obesity associated cancer type, invasive cancer was found in 200 of the bariatric surgery patients versus 1,331 control patients. This came out to have a cumulative incidence of 6.8 versus 8.3%. So the difference isn't as profound as the previous slide where you're talking about just obesity-associated cancers, but the difference was still statistically significant. Again, to me, you know, the difference looks to become more profound over the years. And this is about the mortality that was related to cancer that occurred in 21 patients in the bariatric group versus 205. In the non-surgical group, the cumulative incidence was 0.8 versus 1.4. Again, it was a significant difference between the two groups with the lower cumulative incidence in the bariatric surgery group. This is looking at the total percentage body weight loss here. Not surprisingly, the bariatric group had significantly lot more weight over the years. They had lost about average of 27.5 kilos versus 2.7 kilos in the control group, which translates into 19% greater weight loss from the surgery. And the difference is pretty much sustained over the 10-year period with a pretty profound gap. And this actually, I think it was really interesting. This actually shows the cumulative incidence of obesity-associated cancers, but they stratified it into different groups depending on how much the bariatric surgical patients, depending on how much weight they lost. So the quartile one in the orange line shows the group of bariatric surgical patients who lost the least amount of weight versus the white line shows the quartile 4 who had lost more than 39% of had percentage body weight loss. So they had the most weight loss. And you could see that essentially the more weight loss you had, the lower the cumulative incidence was. And that is a pretty, you know, straightforward, like dose dependent manner. So I thought that was really, really cool. This was a sensitive analysis. Essentially, I read the sections about 3 times, not 3 times, more like 13 times. So they randomly assigned this surgical index date to the control group. Essentially, they came up with 15 different data sets to perform sensitivity analysis. Essentially, the hazard ratios remain pretty much similar around, you know, 0.6 and 0.8, sort of between that range. And that really, you know, shows that within this data set, through random data sets, that the results are reproducible within this sample. So the authors say that, this supports really the robustness of the findings, which is a positive finding. And then lastly here, I'd like to show is that when the authors only use the occurrence of the 7 cancer types as obesity-associated cancer, and that was based on the Mendelian randomization study, which were the esophagus, renal cell, colon, rectum, pancreas, ovary, and endometrium. They again saw significant difference between the two groups in terms of the cumulative incidence. So, the authors say this was a large observational study. It looked at the effect of weight loss on cancer risk reduction after bariatric surgery. And, they do acknowledge, and I think, I really strongly agree, this is obviously a very difficult area to be studied in a randomized control setting. Cancer is relatively a low sort of an incidence event, and also there's usually a long interval for this type of study that you need to follow them up for. In this case, when from the time of somebody has weight loss to the time of they develop cancer, it could be years, and it could be very long time, which is difficult to do in a randomized control trial fashion. And so far, currently, there's really limited data on the association between actually losing weight and reduced cancer-related mortality. And some of the previous studies that this paper sort of mentioned are sort of limited because they're older data. Some of the studies are based on older surgical techniques, such as banding, gastroplasty, and also they weren't as robust in terms of their matching to their control group. So this study, which includes these modern bariatric surgical techniques with very robust methods, adds a lot of values to the pre-existing data, I think, to support this bariatric surgery in reducing the risk of cancer incidence. And still, the mechanism of increased cancer risk and obesity is not really clear. It's thought that the excess adipose tissue induces chronic inflammation, increased release of hormones, steroid hormones, and adipokines, and also induces insulin resistance with hyperinsulinemia. And so far, endometrial cancer pretty much is the most, probably most widely studied in terms of this cancer association with obesity. And in addition to that, bariatric surgery, can technically or theoretically, and it's also been proven that it reduces inflammation and hyperinsulinemia, which can lead to decreased state of inflammation, reduce inflammation and reduce cancer risk. And currently, I think what's more pertinent from this study is that sleeve gastrectomy and bypass are some of the most common bariatric procedures performed every day in the United States currently. So I think this study is also relevant in the current era, that they assess the effects of these surgeries that are being performed every day on cancer risk reduction through also very close follow-up. The authors mentioned that, even though these two types of surgeries have different physiological effects, we see that they both have similar effects on cancer risk reduction, at least during that 10-year period. And they also proved that cancer risk reduction occurred in a dose-dependent response, and I think that proves for a stronger argument to associate weight loss with the degree of cancer reduction. I think lastly, they do say that the separation of the Kaplan-Meier curves that showed sort of variation of start to really sort of separate only after sort of 6 years after the index date, and their median follow-up was about 6 years. So they also mentioned that in some of their limitations. So the limitations written and addressed by the authors, firstly, they state that there may have been some residual unmeasured confounders, which is a limitation of a sort of retrospective study and a randomized trial. There may also be a selection bias because patients with obesity may be reluctant to undergo cancer screening, and that may cause surveillance bias. But actually, from what I was looking at in table 1, the study showed that actually a larger proportion of patients who had surgery underwent cancer screening before the index day compared to the one who did not have surgery. So I think perhaps there's more patients who tend to get surgery are more likely to be adherent to follow-up and healthcare screening. So that's a sort of an interesting point. Only 7 out of the 13 cancer types that they included in the study have causal association with obesity based on recent research. So I don't know if it's a sort of technical limitation. I think it's just what the current research has shown so far. And again, what I mentioned about the median follow-up of 6 years, I think having a long follow-up, I think it's difficult in the healthcare system we have. But, for cancer incidence, study follow-up, obviously, you want to have longer term follow-up, but also, patients who have surgery, I think it's also hard to keep them, to have them keep coming back after all these years. So that's one of the other limitations. One other thing was the race of the participants. So I think it was upwards of 94% of the study participants were either Black or white participants. And that could be a limitation because that might not be as generalizable to other ethnic or racial participants. And also the participants were relatively young. The median age was about 47. So obviously they're going to have lower incidence of cancer, and cancer is a relatively rare thing. So that could be a limitation in terms of detecting the real difference or the growth difference it could make. So the conclusion of this study states that among adults with obesity, bariatric surgery compared with no surgery was associated with a significantly lower incidence of obesity-associated cancer and cancer-related mortality. And here are sort of my thoughts after reading this article. I think a lot of people would agree that this article gives a strong argument, strong basis to support bariatric surgery and advertise its benefits to the public. And I think even some of the sort of healthcare providers who may not be aware of this, that bariatric surgery is not just for the weight loss, it's not for diabetes management and metabolic syndrome, but it's also, it actually really reduces the risk of various common cancers and associated mortality. And I think this could even make a stronger argument to recommend bariatric surgery in those who may be considered perhaps higher risk of cancer, whether it's due to their sort of a behavioral risk or whether there's family history. And I think also being this a large study based on robust methods and considered result findings, I think something like this can be used to advocate for patients with obesity to have easier access to bariatric surgery, to policymakers, insurance companies, and other care providers who may have more connections with it, such as in the primary care. And I would sort of go as far as saying that, bariatric surgery should be offered maybe more widely to adolescents and young adults, because it takes quite a while for these kinds to have effect. But then also, I think with the longer term effects, I think it makes it a stronger argument to advocate it for younger patients. But I think it will be interesting to see sort of longer term data on this as well. And this, thank you, Dr. Aminian, for sending me some slides that I could use. But I added a couple more sort of media coverage. This topic is clearly like very extensively covered. But I think there's still a lot of people out there who really, bariatric surgery, the only benefit is really for the weight loss and to look good. So I think this message still needs to be continued to be reiterated to everybody over, and it should continue to do that. But thank you very much for listening.
That was awesome. Thank you very much for doing such a nice recap.
Thank you.
Dr. Aminian, I don't know if you have any like comments or kind of initial thoughts about some of the important things you were thinking about when you designed the study, or some of the important findings, just to kind of get things started. And then certainly, I'm sure there are a lot of questions from the panelists and the audience about this study. So.
Sure. Hi, everybody, and thanks, Laura, for the invitation and kind introduction. Thanks, Dr. Choi, for nice presentation. So I like your last slide very much, not the media coverage, your thoughts and your conclusion about this study. So let's start with that. As you pointed out, many people know that obesity is linked to diabetes, to fatty liver, to cardiovascular disease, but only a few people, a few percentage of people know that obesity is linked to cancer. And I think that's the message that we can work on that. Actually, after smoking, obesity is the most common preventable risk factor for a cancer. And with growing prevalence of obesity in this country, it's estimated that in less than 10 years, obesity is going to take over the smoking place as the most common preventable risk factor for cancer. So the impact of obesity on the cancer is huge. So actually around 40-45% of cancers that are currently diagnosed in this country are linked to obesity, and it's getting worse and worse. So the most important message of this study is that if we help a patient to lose weight, and if patients are able to keep the weight off for a long period of time, we can prevent that important health consequence of obesity, which is a cancer risk. And the effect size was very large. So surgical patients had lower risk of developing cancer by 30%. That's a very large effect size. And the risk of dying from cancer was 50% in the surgical group. So the absolute numbers were small, as you pointed out, Dr. Choi. So over the course of 10 years, 3% in the surgical group developed cancer, only 3%. In the control group, almost 5%. So, you need a very large study and you need very long follow-up time to get to the statistical significance of those differences. But decreasing the risk of cancer by 30% and lowering the risk of dying from cancer by 50% are really large effect size. And the findings were consistent in all the subgroups, regardless of being white or black, young or old, low BMI or high BMI, having diabetes or not having diabetes. In all those subgroups, the findings were consistent. So that means if we help our patients to lose weight, if we help the patient to keep the weight off for a long period of time, we can lower the risk of all health consequences associated with obesity, including cancer. That was the topic for this paper and for this meeting. I think that's the most important message of the study. But patients need to lose large amount of weight. So we know that if the patient lose 5% of their weight, they feel better, their diabetes may get better. If they lose about 10% of their body weight, their risk of cardiovascular disease is going to decrease. Their risk of fatty liver disease may decrease. Their risk of their sleep apnea may improve. They're probably going to be more mobile, more active, going to have more energy. But in your slide that you show that those dependent response that we stratified the weight loss based on, stratified the cancer risk based on the amount of weight that the patient lost. So patient in the first quartile, patient who lost only 20 to 25% of their body weight, they didn't decrease the risk of cancer. So patient needed to lose much larger than 20 to 25% of their body weight to decrease the risk of cancer. And that's important. All these current medication and all noises about them, they provide maybe 15 to 20%. So they're going to help for diabetes for sure, they can help for cardiovascular disease, but they may not be helpful to lower the risk of cancer. So patients in
My
this
questions.
so
I
in
was going to
this-
ask you that question about
Mhm.
lost medications. I've
Yeah,
been getting
so-
asked a lot. Mhm.
If you can show that slide, because that's important. Dr. Choi, can you share your slide that dose dependent response? That's important because we always talk about the weight loss threshold that can provide health benefit. And traditionally, this threshold has been always 5 to 10%. But as you see here, the first quartile of patients who lost less than 24% of their body weight, they didn't decrease the risk of cancer. And then the last quartile who lost almost 40% or over 40%, significantly dropped their cancer risk. So this amount of weight loss currently is only achievable with the surgery. So medications usually cannot provide that extent of weight loss. And the other conclusion from this slide is that it's very important to help patients to keep the weight off for a long period of time, and the threshold that we should consider for a cancer risk is much higher than 5 to 10% threshold that we always talk about it, or we usually consider that as an appropriate weight loss threshold. And if you go back to the previous slide, or one more, back, go back. Yeah, so yeah, stay here. This is the other point that would be interesting for the surgeon, because surgeons always want to see the differential effect of bypass versus sleeve. That's whatever you present about the effect of the surgery, surgeons always ask, okay, so how about sleeve versus bypass? How about procedure A versus procedure B? So as you see here, the KM curves of the sleeve and bypass are almost completely overlapping. So both were much better than the non-surgical control group, but there is no difference between the sleeve and bypass. Again, we know that the gastric bypass is more powerful than the sleeve, right? So patients usually lose more weight in gastric bypass than the sleeve. They usually are able to to keep the weight off for a longer period of time than the sleeve. So overall, bypass is a stronger procedure. Bypass is overall better than for diabetes. Bypass, there are some evidence that bypass can lower the risk of cardiovascular events, heart attack and stroke and nephropathy better than the sleeve. But for a cancer standpoint, it seems like the difference between weight loss between these two procedures is not that large that could influence the cancer risk. So that's why you see almost complete overlap of the KM curve of bypass versus the sleeve. So again, for diabetes, for cardiovascular disease, for weight loss, bypass is a stronger, more powerful tool to help patients. But from a cancer standpoint, seems like that difference in the weight loss is not large enough between two procedures that can lower the risk of cancer development after bypass more than the sleeve. And I think that's important. And just one slide back. And
Do you think there's any chance that those might split beyond 10 years?
Yeah, it could be. I mean, if the sleeve patient gain weight over time, And yeah, I want to talk about that long-term follow-up that Dr. Choi also mentioned. Go to the back. One more. Okay. To the obesity-associated cancer. The primary endpoint is. So that was the primary endpoint of the study. So risk of developing 13 different type of cancers. So you see here the first year, almost zero cancer, and then slowly, gradually, patient develop cancer. But up to year 6, it's almost parallel. And then around year 6, you see a separation of the curves, and it get wider and wider over time. So this study concluded that the surgery would decrease the risk of developing cancer by 32%. But I think the study actually underestimate that because the follow-up is 10 years. If we follow this cohort for 20 years, this gap gonna be wider and wider. And maybe in 20 years, the difference would be 50% or 60% or 80%. But up to 10 years, surgery could decrease the risk of cancer by 32%. But based on this graph, you see that gap is getting wider and wider. So it would be interesting to follow these patients additional 5 years, 10 years to see what's going to happen. But I would suspect that this gap going to be larger. And that's why you cannot do this type of studies in the setting of randomized clinical trial. So you cannot randomize 30,000 patients and follow them for 10 years. The largest RCT that we have in the field was Stampede with 150 patients. So that's why you need the large cohort studies and follow them over the time, because as you see, only 3% versus 5% in the other group develop cancer over the course of 10 years. So overall, it's a rare event. That's why we need a very large sample size and very long follow-up time. I think these are the points at this point. But if any questions audience have.
So I'd like to start, if you don't mind. I guess I had my hand up. That's kind of awkward as a panelist, but I thought this is such an elegant study, and I didn't want to interrupt your commentary because I was just so curious to hear, what it was like to be on the, I guess, the side of actually producing the study. But I do have a couple of questions. So the first one is that you talk about the % total weight loss, and we know that patients at even at larger BMIs they end up losing more weight after surgery. So their total weight loss is higher. So I'm wondering whether you looked at whether or not there was a difference with the cancer rates based on a BMI or the change in BMI for these patients.
So based on their baseline BMI, there was no change. So if a patient was on the low side BMI or high side BMI at the time of the surgery, there was no difference in terms of the effect of surgery on reducing the cancer risk. But it's going to be very difficult to look at the different trajectories of the weight on the cancer risk. So the best way that we could come up and show the weight loss, the effect of weight loss on cancer risk was the slide that we presented, that we could stratify the weight loss that was achieved in the first 2 years after surgery. We stratified the cancer risk based on the weight loss that was achieved in the first 2 years of the surgery, and it showed a dose-dependent response. So patients who lost more weight in the first 2 years of the surgery had low risk of cancer compared to a patient who lost less weight in the first 2 years.
Okay. And then my second question is, when you look at the stratification, I guess, are we identifying certain subsets of patients who would benefit more from having bariatric surgery? Like, are we changing? And, Dr. Choi talked about this. So she mentioned the primary risk reduction. Are we identifying patients who would most benefit from that? And then what would your recommendation be then for patients that we're seeing in clinic?
Very good question, Julie. So again, in all subgroups that we looked at, we saw the benefit of the surgery. There was no difference. But obviously, we can't operate on 100 million people with obesity in this country, right? To decrease the risk of cancer.
Wait,
but
why?
Some patients who are at extremely elevated risk for a cancer needs to be prioritized to get the surgery. So as Dr. Choi presented, among all the cancers, endometrial cancer has the strongest association with obesity. And when we looked at the specific cancer types, the only cancer, because of the sample size issue and the power issue, the only cancer that reached to the statistical significance was the endometrial cancer. So that's why we had that composite endpoint of 13 different type of cancer. We lumped them together to increase the power, because then event rate was very small. Even with lumping all together 13 different type of cancer, we had 3% versus 5%. So the only cancer, individual cancer type that reached to the statistical significance was endometrial cancer. So overall, endometrial cancer has the strongest association with obesity among all the cancers. And bariatric surgery has the largest effect on reduction in risk of endometrial cancer, so by 50% in this study. So that means patients who are at risk to develop endometrial cancer should be prioritized to get surgery, or should be prioritized to lose, to have access to something to help them to lose over 20-25% of their body weight. And currently, that's only bariatric surgery. So if the patient has endometrial hyperplasia, atypical endometrial hyperplasia, so that patient needs to be prioritized. So we need to talk to our GYN colleagues and educate them that if we help patients with endometrial hyperplasia, we can decrease the risk of endometrial cancer. And the same concept with other pre-malignant lesions. So if the patient has Barrett esophagus, if the patient has high-risk colorectal polyp, or high-risk breast lesion, BCIS or LCIS, or ductal hyperplasia, any of those high-risk breast lesions that are at risk to develop breast cancer. Or what else? Any of those pre-malignant lesions for the cancers that are linked to obesity. So if we have those patients, so obviously those patients need to be prioritized to get the surgery. In addition to taking care of that lesion, if that's a DCIS needs to come out, or if the LCIS patient needs to get a tamoxifen, or if it's a Barrett needs the endoscopic ablation, or if the colorectal polyp needs to be removed, or for endometrial hyperplasia needs to get the IUD or hormone therapy, whatever. But in addition to that, if we help those type of patients with those high-risk lesions to lose weight, I think gonna be really, really helpful and impactful. As I said, we can't operate on 100 million people with obesity, but if we want to decrease the risk of cancer in a large number of people, we need to target patients who are at risk to develop cancers, and people who have those benign or borderline high-risk lesions are at risk to develop malignant tumors. So we need to work with our colleagues in the other fields, and hopefully that's going to improve the referral and collaboration to help those patients who are at risk to develop cancers.
Ali, Adrian, Dan here. I've got a couple comments and a couple questions. So first, congratulations to you and the other authors. I know Rakisha is also on the call for just a wonderful study that really adds to the armamentarium of evidence and literature that we have to present to our colleagues.
So actually, Adrian Rikisha did all the job.
She did all the
I just
scholarwork.
put my name as a first author, her name was the second.
That's what you do when you're the big boss. But congratulations to everyone for just a wonderful, wonderful article. Also, I would tell the fellows to be ready to be challenged by other people who say, well, you know, look, people who get bariatric surgery are more likely to get medical care, as we've mentioned, more likely to get screening, etc. But I think it's without a doubt that for whatever reason, most likely there's other mechanisms also involved rather than just that. For whatever reason, we are seeing a major decrease. So my questions to you and anybody else who has expertise in public health: have we looked at some of the other things that are being done and accepted as dogma and unchallenged in our healthcare system, where we spend a lot of dollars on things that may or may not prevent cancer, at least not to the degree that bariatric surgery does? We know there was a study from Europe a couple of years ago looking at the effectiveness of colonoscopy and challenging that. Have you looked at any of the other things that we just do and never even question? Because all too often we're asked to bring these patients back from the edge of the cliff rather than actually understanding the great the preventive capabilities of bariatric surgery that are outlined in this study and other studies you've done in the cardiovascular realm. But have we looked at that? And the other thing I want you to comment on, there's some studies out there that say, well, look, you know, in certain population, looks like there may be a higher rate of colon cancer. And how does that, you know, how do you explain that, and how does that kind of fit into the whole argument?
Good question. So the second one is the easy to answer. I'm going to start with that one. So let's forget that argument that the surgery may increase the risk of colon cancer. So all the studies from 20 years ago came from single group of authors, most of them, and that happened because of not robust statistical analysis. So they didn't have a matched comparable control group. So they compare the risk of colorectal cancer in patient who had bariatric surgery with the prevalence of standardized prevalence of cancer in the population. And that was not a good way to match or to compare the risk of cancer. So 3-4 studies published in Annals of Surgery and the other journals about 10-15 years ago. And then subsequent studies showed that those results were not real. So actually, colorectal cancers are one of those cancers that are linked to obesity. So it's expected that when patients lose weight, the risk of colorectal cancer is going to decrease. So again, in our studies, since we didn't have enough cases, the difference didn't reach to a statistical significance, as I tried to explain. Only for endometrial cancer reached to a statistical significance. But in the SOS study, because they had 30 years of follow-up, it reached the statistical significance. So surgery did not increase the risk of colorectal cancer. So I think we shouldn't worry about those. It just came out from one group of authors that use the national database of different European and Scandinavian countries and publish those data. So I'm not worried about that. But in terms of the effect of the magnitude of effect of the surgery on the cancer risk compared to the screening or the other intervention, so it's hard to compare. But I mean, screening is important. So obviously, because if the patient has borderline or early form of the disease, can be picked up by the screening. So we can't say that the surgery can be a replacement for the screening. But again, in 8 years from now, by 2030, is expected 1 out of 2 Americans will have obesity. So it's just unbelievable. 1 out of 2 will have obesity. 1 out of 4 will have severe obesity. And then obesity gonna be the most common risk factor for cancer. So, and we know that, obesity has different health consequences. Maybe cancer is, and if you look at the largest scale, maybe is the smallest one, because maybe 2%, 3% of patients develop cancer in long term, but 45 or 50% may develop cardiovascular disease. So the advantage of bariatric surgery or any weight loss intervention is that it takes care of all the health consequences of obesity, and that's really important. So patients with obesity can develop diabetes or high blood pressure, cardiovascular disease, and fatty liver disease, and sleep apnea. So instead of putting patient on 3 diabetes medication and insulin and 2 high blood pressure medication and medication for heart failure and new medication for fatty liver disease and what else? The CPAP and pain medication for a joint pain and some antidepressant for the depression and anti-anxiety medications. And all those medications, and patients still going to be at risk for developing cancer while taking 10 different medications. So it makes sense, right, to just attack the root cause of all these problems, which is excess weight, and going to help patients to stay healthier, get rid of all those medications, and enjoy the life better. But it's very unfortunate that this approach is not adopted by medical community. So every specialty takes a small piece of that and put patient on medications to just treat that piece. Endocrinologists keep adding diabetes medications. Cardiologists keep adding cardiovascular medication. Nephrologists keep adding hypertensive medications and so on. So I hope at some point we go toward that route, that we address the root cause of all these health consequences that the patient have. And it's enormous and it's very large. I mean, in 8 years, 50% of people in this country will suffer from obesity. So it's huge.
We have a couple questions from our audience. Just before we get to those, one of the things that I keep thinking about with your paper is how just kind of historically in our community for bariatric surgery, how hard we've had to work to show the medical community the benefits of what we do, and that there has been this kind of this idea that the prospective randomized controlled double-blinded clinical trial is the gold standard, and that if you can't prove it with that, it's not real. And one of the things I really love about your study is how powerful it is in showing something that literally cannot be shown any other way. And I think because what we do changes the trajectory of people's lives health-wise kind of in the decade time scale rather than in the week to month time scale, that we really do need to just basically all get together and pool our data to be able to see all of these effects.
Yeah, good point. I mean, when you talk to the clinic, to the medical folks, they always want the randomized clinical trial. So they wanted from 15 years ago, 20 years ago. And the field progressed significantly. So now we have 15, 20 randomized clinical trials. But despite all the effort that we had, all those randomized trials have 50, 100, 150, 200 patients in total. So it's extremely difficult to randomize patient to surgery versus no surgery. It's not like drug A versus drug B. So it's a surgery that has lifelong changes in the body. It's not like a drug A that if you decide not to take it, then you can just stop it. So I think their mentality needs to be changed, and that's important, and that's unfortunate. And for the cancer specifically, so we know that smoking is bad and it's associated with cancer, but there is no study that showing smoking cessation versus continuing smoking. There is no RCT that comparing stopping smoking versus continuing smoking can decrease or could decrease the risk of lung cancer or any type of cancer. So that's the same concept with obesity. So the medical folks couldn't do that study to randomize patients who smoke, like a patient who have obesity, and randomize them as a group, stop smoking, force them to stop smoking, the other group continue smoking, and then follow lung cancer in 10 years. The same concept here. We can't randomize patients. It's just impossible. It's impossible. But when you don't have the randomized clinical trial from the observation studies, you may get conclusive data if certain conditions happen. One is the effect size. If the effect size is very large, that's conclusive. If you see the results are consistent among different observational studies, that's going to help. If you see the results are consistent in different subgroups of patients, I think that's helpful. If you see the dose-dependent response between the intervention and the outcome, as we shown here, there was a dose-dependent response between the amount of weight loss and the outcome. So I think that's going to help. So all these elements going to add to the robustness of findings. But we can't wait for the RCT because that's not gonna happen. But I understand. So they always criticize, but that's what it is. But we are in a better position now compared to 10 years, 15 years ago. I think Adrian Dan, who's as old as me, knows that we are in much better position now compared to 10, 15 years ago. So I'm hopeful that 5, 10, 15 years from now, we're going to be in much better position than now. Would you agree with that, Adrian?
I would completely agree with that. And I'm also going to say that it's studies like this that chip away at the doubters. It's okay. And I'm also going to add, I liked your example on no randomized control study for smoking versus non-smoking, but also where's the randomized control study on insulin use versus no insulin use? So of course things can become mainstream without that level of evidence. But like you said, it would be, some would argue, very difficult, very costly, unnecessary, and some would even argue unethical to tell someone that they cannot have bariatric surgery because they've been randomized to the therapy that's clearly inferior. So that's what I would say to that, but completely agree. And we're going to keep, we're going to keep going forward and fighting the good fight, because eventually people will realize the potency and the effectiveness of what we do.
There's a question in the chat. I just wanted to quickly put to you because we are at the end of our time. Do you think that this study should change the screening guidelines to include obesity for screening for different types of cancer?
You're muted, Dr. Aminian.
Oh, sorry. So I think it's important to spread that message to the primary care physicians and to oncologists or whoever work with patients with cancer, that obesity is a risk factor and help patients to lose weight, can decrease that risk. I think it's important. Again, this is good for patients who are at lower risk of developing cancer. But as we discussed, if the patient already has those high-risk lesions, those, in my opinion, need to be prioritized to get to bariatric surgery.
Yeah, and I do wonder how much kind of information like this over time will help point to some of the pathophysiology, because if you're not seeing the difference until 6 years, it makes you wonder what are we really getting at with the bariatric surgery kind of on the genetic level that then 5 to 6 years later is turning into a cancer that can be detected. So
yeah, I mean, there are a lot of unknowns. But the thing that we know is that the effect of surgery on diabetes is immediate, right? All of us do surgery, patients are insulin, go home without insulin, or a week after they stop diabetes medication. So effect on cardiovascular disease, you see that in 2-3 years, the risk of developing cardiovascular disease is going to decrease in 1 year, 2 years, 3 years. But the effect of cancer is very long. So it takes at least 6 years to see the effect.
yeah. And just one last question, because it's a good one. In your study, were you able to do any analyses that look at factors that may decrease the risk of cancer that we can start looking at?
We only looked at the effect of the surgery, but we consider 30 different baseline factors and match the group based on those variables. So the question here was not to look at the other factors that could contribute the risk of cancer. We just wanted to see if intentional weight loss could decrease the risk of developing cancer. And the answer was that the effect of intentional weight loss was very large on the cancer risk.
Awesome. Well, we're just a few minutes over. Does anybody else have any questions, burning questions? Awesome. This was really, really amazing. Thank you so much, Dr. Aminian and Dr. Choi. That was a really excellent presentation. And I'm sure all of our fellows enjoyed listening and learning about this. Definitely one of my main research interests. So thank you all for joining, and I hope you all have a good night, and we look forward to seeing you next month. What are we doing next month, Julianne?
It's going to be discussing the SADI duodenal switch. So we'll have Dr. Poulat, who's like a phenomenal leader in the field of DS. He'll be showing you how he does it and how to manage any issues that you have or any complications while you're operating.
Awesome. So we would love to see you all on March 23rd for our video session on SADI. But thank you all. Have a wonderful